we will continue the second part of the lecture, which is the urinary tract infection. The most common pathogen is E. coli. Other causative organisms could be Staph aureus, Proteus, and Klebsiella. The incidence, the recurrence of a previous cystitis and pyelitis. The woman may have pre-pregnancy or during a pregnancy a cystitis or pyelonephritis, so she will experience more risk of this infection in the postpartum period. The infection could be contracted due to frequent catheterization during labor or early puerperium. The woman may have retention of urine in the puerperial period, as we mentioned. The postpartum asymptomatic bacteriuria. This occurs in 3 to 34% of patients, resulting in symptomatic infection in approximately 2% of those patients. That's to say, the woman may have asymptomatic bacteriuria. Accidentally, we sent for general urine and we will see that there is bacteria in the urine. And this woman may have 2% incidence to be complicated to symptomatic one. The symptoms, the patient may have frequency, urgency, dysuria, hematuria, suprapubic or lower abdominal pain. The pain may have more higher up in the loin area. She may have fever, rigor, or she may have, as we mentioned, no symptoms at all. On examination, the vital signs could be stable, afebrile, or if it is severe, we may have fever. That's to say there is increase in her temperature. She may have suprapubic tenderness and renal angle tenderness. If we have renal angle tenderness, this could be due to upper urinary tract infection. We have to send for general urine analysis, urine culture from either a clean cut or catheterized specimen, and we may send for CBC. The treatment is started with 3 or 7 days antibiotic regime. Most suitable one is amoxicillin, and it's often still used, but it has lower cure rate secondary to increasing resistance of E. coli. Quinolone, very effective, for example Ciprodar, but are considerably expensive than amoxicillin and should not be used in breastfeeder mothers. We may have a bladder dysfunction. The oxytocin commonly infused after placental delivery. There is sudden withdrawal of the anti-diuretic effect of this oxytocin, so they reflexly will have rapid bladder filling. Both the bladder sensation and its capability to empty will be affected, and this is due to anesthesia or due to episiotomy or laceration or hematoma in the perineum. So the woman will lose or decrease in her sensation for the fullness of the bladder, so she may experience urinary retention with the bladder overdistension, and it is a common complication in the early puerperium. The treatment for this distension, we should put catheter for the woman for 24 hours, and once we remove the catheter, if the woman cannot void, put it again and measure the urinary residual volume. If it is more than 200 cc, again put the catheter and leave it till the bladder is drained for another day. If it is less than 200 cc of urine, the residual volume, remove the catheter and recheck the bladder, give some analgesia, encourage for mobilization, warm bath, and some physiotherapy, and the problem will be corrected. This picture shows to you details of the anatomy of the breast, and each point is marked with A, B, C, D, E, F, G, and all these are parts of the breast. Regarding lactation, we all heard about the colostrum, It is deep lemon yellow colored liquid secreted initially by the breasts. It's expressed from the nipple by the second postpartum day, and it contains more minerals, protein, globulin, with less sugar and fat. The antibodies, especially IgA, is also present. It persists for a few days, about 600 ml per day. It contains major protein, including B, alpha-lactalbumin, beta-lactoglobulin, and casein. The breastfeeding benefits are so much. We have predominance of immunoglobulins, especially secretory IgA, which will works against E. coli. So, breastfed infants are less prone to enteric infections. It contains both T and B lymphocytes, so this will encourage the immunity in the neonate. The breastfeeding accelerates uterine involution, as we mentioned in the previous slide, that there will be an endogenous oxytocin release, and this will cause contraction of the uterus, so it will give a benefit to decrease the incidence of postpartum hemorrhage. Inhibitors for milk excretion, medication, for example, bromocriptine or cabergoline. Contraception. The contraception not needed in the first 3 weeks postpartum, because during this period there is delay in the regain of ovulation. After 3 weeks postpartum period, we should think about contraception. The most suitable one in breastfeeding women is a progestin-only contraception. We call it mini pills. Or we have depot medroxyprogesterone injection, which will give contraception for 3 months. Or we can use levonorgestrel implants. Progestin medication, it will not affect the quality and the amount of milk expression. The contraception of choice for the breastfeeding mother is the progestin-only preparations. Estrogen-progestin contraceptions, we mean the combined pills, they reduce the quantity and the quality of breast milk. The puerperal women have a predisposition to venous thrombosis, so once we giving this combined contraceptive pills, it will increase the risk of DVT and arterial venous thrombosis. Low-dose pills are preferred if used in lactating women. For example, microgynon or Yasmin. They contain 30 microgram of ethinyl estradiol. The contraindication for breastfeeding in women with alcoholic use, if she had an infant with galactosemia, if the women have an HIV infection, if there is an active or untreated tuberculosis in the mother, if she takes certain medication that's transmitted through the milk, if she is undergoing breast cancer treatment, so I will postpone or prevent breastfeeding. We have some breast problems happens in the puerperal period. One of them is breast fever. This is due to engorgement. After development of the milk secretion, the breast becomes distended, firm, and nodular, with exaggeration of normal venous and lymphatic congestion. Engorgement of the breast happens in 2 to 4 days postpartum. This will create puerperal fever from this breast engorgement. The temperature is about 37.8 to 39. It seldomly persists for longer than 16 hours. Other causes, especially infection or fever, must be excluded. We can treat it by using good strong braziers, ice packing, analgesia, pumping, or manual expression of the milk. So evacuation of the milk ducts will decrease this engorgement. Most women will experience cracked nipple. This is due to some women have retracted nipples embedded in the breast. So, from the trauma of the mouth of the fetus, this will cause abrasion or erosion of this nipple. And it's followed by crust formation, and sometimes it is due to poor lactational position. It occurs due to loss of surface epithelium or due to fissures situated at the tip of or the base of the nipples. And once we correct the position of lactation, that's to say putting the darkened area around the nipple inside the mouth, so the suckling or trauma from the mouth of the fetus will not affect the nipples, and with time it will be resolved. Some women will have mastitis. This is due to parenchymatous infection of the mammary gland and seldomly appear at the end of the first week postpartum. Usually, it occurs in the first 3-4 weeks after delivery. They will have unilateral breast hardness, redness, painful tenderness. The women may experience chills, rigor, fever, and tachycardia. This is mostly due to microorganisms Staph aureus and sometimes strep viridans. It may be complicated by breast abscess, and almost always from nursing infant's nose and throat, the microorganisms enter the breast through the nipple through the site of the fissure or abrasion, and this will result in this mastitis and breast abscess. The treatment is by swab and culture, antimicrobial therapy by flucloxacillin or cephalosporin, or sometimes vancomycin. It continues for about 7 to 10 days. Continue please milk expression, don't stop it. Stop breastfeeding only if infection or abscess is formed. Surgical drainage is essential if the abscess is developed, and general anesthesia can be used for this condition. And the feeding should be stopped till after healing. So, the woman in the postpartum period needs from us a hospital care. Attention immediately after labor for the first hours after delivery, because she's liable for postpartum hemorrhage. So I should check blood pressure, pulse rate. First few hours every 15 minutes, and then once you make sure that the woman is stable, you can make it more than this time, for example every 4 hours. Monitor the amount of vaginal bleeding. This is the crucial major points in the follow-up. The uterine fundus should be palpated to make sure that it is contracted, because if it is relaxed, this is a risk for, you know what? Yes, postpartum hemorrhage. You should advise for early ambulation because it will have less frequent bladder complication and constipation. It will have reduced frequency of peripheral venous thrombosis and stasis. Also, risk of pulmonary embolism will decrease with mobilization of the women. Women who has not voided within 4 hours after delivery, please put a catheter to prevent over distension. Some women will have depression. Some degree of depression the first few days after delivery is common. We call it postpartum blues, and this is usually a transient one. It's caused by the emotional letdown that follows the excitement and fear that most women experience during pregnancy and delivery. The discomfort of early puerperium. The woman has a baby and she doesn't prepare herself to deal with it. Some women will have fatigue from loss of sleep during labor and postpartum period in most hospital settings. Anxiety over her capability of caring of her infants after leaving the hospital. She's afraid that she's not be able to deal with this baby. Fear that she has become less attractive from her husband, and this may affect her marital status. It's usually a self-limited and mild and remains for 2 to 3 days, and then with time it is resolved. The immunization in the puerperial period, we should advise for NTD 300 microgram for non-immunized Rh negative women with an Rh positive baby, and this injection should be given within 72 hours of birth. Rubella vaccination for non-immunized women. Diphtheria tetanus toxoids booster should be given. Measles immunization also advised. The return of menstruation and ovulation, if not nursing, usually return within 6 to 8 weeks. Lactating women, first period may occur in the 2nd or 18th month after delivery. It may take prolonged time to return to menstruation. Ovulation, it usually occurs early as possible, as 5 to 6 weeks after delivery, sometimes even 3 weeks after delivery, after the end of 3 weeks. Delayed resumption of ovulation with breastfeeding. Complete breastfeeding may delay ovulation, but early ovulation is not precluded by persistent lactation. Pregnancy can occur within lactation, so take care. It is not a method of contraception. Some women will experience obstetrical paralysis. This is due to pressure of branches of lumbosacral plexus during labor. She will complain from intense neuralgia or cramp-like pain, extending down through one or both legs as soon as the fetal head begins to descend to the pelvis. It involves sometimes external popliteal nerves or femoral nerves or obturator nerve or sciatic one. Separation of symphysis pubis or diastasis or one of the sacroiliac synchondrosis during labor may be followed by pain and marked interference with mobilization. The women may have wobbling gait due to separation of the symphysis pubis. Thromboembolic disease also can occur in the puerperium, and this will be discussed in a separate lecture. And also postpartum hemorrhage is one of the major complications, and it will be taken in details by other lectures. And thank you. Please, if you have any question, don't hesitate to ask me. Thank you.